This episode is brought to you in collaboration with NephMadness and AJKD, and that probably means that Hannah's back to punish me with yet another pun.
I am! Aren't you excited, Paul? All right, so this week's pun is from Edward Cordy, who's an MS3 at Florida State College of Medicine. And here goes.
This is Edward Cordy. I'm a third-year med student at Florida State, and I got help from my brother Robert, who's a fourth year at UNC. What is the animal-loving nephrologist's favorite hobby?
I don't know.
Collecting ducks.
All right.
That was my favorite.
Two of you to create that? That was a two-person operation. I've never been angrier.
I love Paul's reaction. Totally worth it.
All right. And now on to the episode.
The Curbsiders podcast is for entertainment, education, and information purposes only, and the topics discussed should not be used solely to diagnose, treat, cure, or prevent any diseases or conditions. Furthermore, the views and statements expressed on this podcast are solely those of the host and should not be interpreted to reflect the official policy or position of any entity aside from possibly Cash Like Moral Hospital and affiliate outreach programs. If indeed there are any, in fact, there are none. Pretty much, we aren't responsible if you screw up. You should always do your own homework and let us know when we're wrong.
This episode of the Curbsiders is sponsored by the American College of Physicians, a professional society for internists with over 154,000 members. For a limited time, post-training docs save $100 on their first-year membership dues. Visit acponline.org/join and use the code CURB100 to get your discount. That's
what was that code again?
That's CURB100.
Are there any spaces in that?
No spaces. Welcome back to the Curbsiders. This is your host, Dr. Matthew Frank Watto, without any of my normal co-hosts tonight, so I'm going to do a very quick intro. This, of course, is the Internal Medicine podcast where we strive to bring you clinical pearls and practice-changing knowledge. As you should know by now, the first 10 to 15 minutes of the show are spent just chatting as colleagues, getting book recommendations, talking about work-life fit. So if that's not your thing, you can look at the timestamps and skip ahead. On this episode, we will be talking about everything that our Curbsiders team could think to ask about hepatorenal syndrome. We go through pathophysiology, differential diagnosis, the basic workup. Should you do large volume paracentesis? Should you give diuretics? Should you do albumin challenge? If so, how much and how often? We go through it all. We talk about terlipressin. We talk about norepi. It's all there. Our guests are a wonderful team from NephMadness, and I'm going to give quick introductions, quicker than usual, because they do a great job of introducing themselves in the next portion of the show. Our first guest is Dr. Bill Whittier. He is an associate professor and academic nephrologist at Rush University in Chicago. Our next guest is Dr. Juan Carlos Velez, who prefers to be called JC or JCV, as you will hear on the show. He is an associate professor of nephrology and the department chair at the Ochsner Clinic Foundation in New Orleans. And finally, last but not least, our chief of nephrology at Kashlak Memorial, Dr. Joel Topf, is here rocking out for his Curbsider interview number 8. And actually, I'm told by my producer, this is number 9 if you count the fact that one of his episodes was split into 2 parts. He is a clinical nephrologist and medical educator. He is the co-founder of the online Twitter Journal Club, as well as NephMadness, and he is the winner of the 2017 Robert G. Narons Award for Innovations in Teaching from the ASN. This was a fantastic conversation with our 3 guests. So without further ado, let's get on with the show. And no pun. No pun. We are here with 3 wonderful guests for NephMadness, yet another NephMadness episode. And we're going to start out, like always, with some one-liners. And we gotta start with our chief of nephrology, Dr. Joel Topf.
Hi, Joel Topf is a 49-year-old clinical nephrologist. He has managed to straddle the worlds of private practice and academic medicine. He's a partner at St. Clair Nephrology in Detroit while having an academic appointment at William Beaumont Oakland University School of Medicine, where he teaches kidney physiology to second-year medical students. He also does clinical teaching to third years and fourth years, as well as teaching the internal medicine residents and nephrology fellows at Ascension St. John. He's best known as his Twitter alter ego, Kidney Boy.
Joe, I told you too that my kids, they heard the diuretic episode and they were like, this guy sounds like Batman. and then when I told them that I was going to tell you that, they're like 5 and 6. They were like so embarrassed. They're like, don't tell them we said that. So now I'm going to tell them in front of a national audience.
I can neither confirm nor deny whether I'm Batman.
You're a very kidney-specific Batman. Is there a kidney, like a bat signal for the kidney? That's what they do around St. Clair Nephrology. Joel just shows up. Okay, let's talk. Bill, why don't you give the audience a one-liner? This is your first time on the show, so tell them a little bit about yourself and maybe something outside of what you do in medicine.
Sure. Thanks, Matt. I'm an academic nephrologist at Rush University in Chicago, and I've been a nephrologist for about 15 years. I'm active in teaching and clinical research, and I'm probably best known for being the most, as opposed to, except for Joel and JCV, I'm probably known as the most handsome nephrologist in America. Now, I don't know, Matt, have you ever been to a nephrology conference?
Not yet. I'm aspiring to attend one in the future, though.
So being the most handsome nephrologist, if you go there, you will see that this is not actually something that's true. I mean, it's not even so. And the other thing is, if we can make sure this stays audio file as opposed to video, then the myth can live on.
Yeah, my other question was going to be: we are going to have some nephrologists listening to this. Are you sure you want me do you want me to cut this whole part right here? Or
just keep the myth alive, but make sure it's audio only, because I really don't need anybody finding out factual information about this nonsense.
Okay,
so, thanks for having me on, though.
Okay, JC, did you want to give a one-liner about yourself?
Yes, sure. Juan Carlos Velez. I'm a 48-year-old Peruvian nephrologist, practicing nephrology in the United States for also about 15 years, 13 years, lost count. And my Twitter handle is it's at Velez NephHepato, which comes handy with this tonight's discussion. And that reflects one of my main areas of interest, which is hepatorenal physiology. I'm current chair of nephrology at Oxnard Clinic Foundation in New Orleans, where I moved 2 years ago. And outside medicine, my three favorite hobbies are: number 1, to play soccer; number 2, to talk about soccer; and number 3, to watch soccer. So you get the point.
I like it. JC, I'm going to start with you for just some of our routine questions here. Can you give the audience, like, what's some of the best advice that you heard in your career? That's
a good question. I think that the best advice in my career, I will start with a bit of advice at home, which kind of affects all your life, which is don't ever do things to others that don't want them to do to you. And that's kind of what I think every day in life, in general. And it kind of applies to what we do in a hospital too, to take care of the patients like your family and like yourself.
Fantastic. Bill, what about you? Any great advice that you can share with the audience?
I think one of the keys to sort of success in life, whether you're in academics or private practice, is communication. I think there's a lot of times where hepatology will come by and think one thing, and nephrology comes by and thinks another, and we all puff out our chests and say, we must do it this way and we must do it that way. And
cardiology says we have to diurese and we say we have to give fluids and so on. And instead, you just kind of put yourself in the other person's shoes and you see their side of the picture, whether it's clinical medicine around a patient or whether it's any argument in real life. I think that kind of seeing the other person's side is really, really important. And actually, I think this communication gets you a lot more effective ways of being a better person and, taking care of patients too. So I think improving communication is probably the number one key to success.
So the follow-up question would be, any specific resource that taught you that, or is this just like modeling from your mentors or your parents, your family?
Yeah, I have one really, he's a good friend of mine and he's also a mentor, and he wasn't necessarily the brightest person ever, but he treated all the adults ahead of him like a peer. Meaning like he could just like be himself around anyone, right? So he talked to the president of the hospital and he would be himself. And now, because of that, he's like, moved up and up, and I don't have to give his title or anything, but he's moved up and up in the world. And really all it took was really good communication, as opposed to brilliance or working in a lab too long. It was really just being able to communicate. And I think that's really helped out a lot.
Okay. Joel, I think it's been a while since we asked you about some advice. You got anything for us?
No, I was prepared with the pick of the week. I didn't come with. I don't have any.
Okay,
right now.
So let's move into picks of the week then, and I'll let you start. What are you recommending this week?
Okay, so what I'm recommending is Checklist Manifesto. This is one of the books by Atul Gawande, who is a prominent healthcare writer. He's an oncologic surgeon from Hopkins, though he's now working on the Amazon and I think it's Berkshire Hathaway healthcare initiative that they're kind of putting together. If you haven't heard of him, he's kind of like the Malcolm Gladwell of medicine. Like, he picks an interesting topic and just dives deep into it. And one of these topics that he went into is how could we use checklists to improve medicine? And this book just kind of goes through how checklists are used, and we often hear about them in flight, in airlines. But he kind of shows how they're used in a lot of different things. He talks about how you build a skyscraper, and then he talks about implementing checklists for the World Health Organization for surgery and improving safety in surgery. And it's just a fascinating journey. And as I'm reading it, it just kind of exemplifies, like, it, when you listen to the Curbsiders, so much of it is about learning the latest little tricks and the latest advances in medicine. But what really improves patient care is just making sure you do all the basic stuff and don't miss it. Don't forget the sub-Q heparin, right? Like that's going to make a bigger difference than knowing, the latest, how to get the latest genetic testing, right? Just don't miss the basic stuff. And that's what this Checklist Manifesto is about. I'd highly recommend it. It's a great book.
Sponsor for tonight's episode.
That's right. It's the American College of Physicians, or ACP for short.
That's right, Stuart. The ACP is the largest medical specialty society in the world. There are chapters in every state, which means tons of opportunities for all our listeners to get involved in meetings, to go and learn, to network with colleagues, and to add their voice to the advocacy discussions that are going on at home. Also, the ACP is just always doing things at a national level, whether it's trying to improve the mock process, they're lobbying Congress for things like reducing administrative burden, or just putting out policy papers.
And for that reason, I am proud to be a member of the ACP, not just because of the policy statement issues, but also because of their attempts to reduce physician burnout, which is a huge thing for me. In fact, with all of that in mind, there are so many benefits for membership, like the Annals of Internal Medicine in the clinic and beyond the guidelines. And members also get discounts on critical lifelong learning resources like MixApp and the annual internal medicine meeting. Wink, wink.
Yeah, plus there's lots of CME and mock opportunities, not just our show, other shows, other CME and learning activities through the ACP. So in summary, no matter what your career stage or practice setting, ACP can support your needs.
And for a limited time, post-training docs can save $100 on their first membership dues. Visit acponline.org/join and use the code CURB, CURB 100, no spaces, to get your discount.
Well, I think it's time now that we move on to a case from Cashlack Memorial so that we can start talking about the main event here. So this is of course inspired by NephMadness. Bill, you had written about this. You had written about 2 topics for NephMadness, and we decided to sort of make this more general, kind of gear this one more towards our general internist audience. So we're going to start with a case here. This is Mr. Clyde Rosis. He is a 54-year-old male with known cirrhosis from severe alcohol use disorder, and he presents to the emergency department with swollen legs, abdominal distension. He's had previous large volume paracentesis for ascites. He's previously been treated for SBP. He has known varices, previous hospitalizations for hepatic encephalopathy. He's currently being worked up for liver transplant, and previous MELD score was 26. His creatinine was 1.4, INR 1.5 at the time. He takes the following medications: furosemide, spironolactone, lactulose, omeprazole, propranolol for variceal bleeding prophylaxis. He's on trim sulfa for SBP prophylaxis, and he admits sometimes he's not taking all his medications. On admission, a diagnostic paracentesis shows signs of SBP, and he's initiated on treatment with ceftriaxone. The labs on admission are pretty much what we'd expect from someone with end-stage liver disease, but now we're noting that the creatinine is 2.6, his baseline is 1.4, and his serum sodium is 130. So everyone's gonna get a chance to talk here. Bill, I'm gonna start with you. When you see a patient like this, how do you kind of approach this newly elevated creatinine in a patient with cirrhosis?
Yeah, unfortunately, this is becoming more and more common. I think the first thing to make sure, and certainly as somebody who has alcoholic cirrhosis, thinking that there's some sort of hemodynamic insult that's happening to the kidney. But in other patients who have cirrhosis from hepatitis C or possibly autoimmune, they could have another inflammatory glomerular disease going on. The first place you want to start is by just looking at the routine urinalysis and make sure that that's consistent with a hemodynamic mediated injury. No blood, no protein, and make sure it's really just a bland urine. Once you're there, and most often it is there, 95% of the time, and probably 99% of the time in someone with alcohol cirrhosis, then you're looking at some varied degree of not enough blood getting to the kidney. Okay? And there's a lot of different ways to get that, but the 3 main ways that you want to break it down to in your mind is, could this be not enough blood to the kidney, meaning the kidney is just pre-renal, and it's still going to respond to getting that patient to euvolemia? That'd be the first one. The second one would be not enough blood getting to the kidney now that the kidney's in complete shock, which would be ATN or acute tubular necrosis. And then the third one, which is probably the most common, is not enough blood getting to the kidney, and that's because of this persistent liver disease and the physiology that goes behind that. And so the way to sort of sort out those 3 is by using the urine sodium or the fractional excretion of sodium as well. And this is just sort of on a board's view. When you're in practice and in real life, sometimes it doesn't always work out perfectly, kind of like urine eosinophils are an incredible test on your boards. The positive predictive value of urine eosinophils for interstitial nephritis on your boards is somewhere around 98%. But the positive predictive value in real life for urine eosinophils is somewhere around 40%. And it's a horrible test that I've never ordered in 15 years. So some of these things are real life and some of them for the boards. But what you want to really do then after urinalysis is bland is check that the urine sodium is either in the FeNA is either low or not low. And if it's not low, you're possibly in this realm of ATN or acute tubular necrosis. Therapy for that is supportive. The kidney's stunned. We've got to wait and let it get better. Still try to establish euvolemia. And if you're in the low FeNA realm, then the differential comes down to being pre-renal or not. So classically, we would always give a volume challenge. And if everything gets better, then it's just pre-renal. If everything doesn't get better, then you're into this hepatorenal vortex, if you will.
Yeah, I'd like to. Can you hear me? Am I coming through?
Yeah.
Okay. So I'd like to just step in there just kind of from the add on to that bit about the wards and about actually taking care of patients, and that in my mind, in the presence of cirrhosis, you're always going to have a low urine sodium and a low FeNA. And I don't find that, like, again, if the FeNA is elevated, if you have an elevated urine sodium, yeah, you're going to be dealing with ATN. But again, if the FeNA is low, the full differential is still on the table. It can still be ATN, it can still be pre-renal, and it can still be hepatorenal. So I just want to emphasize, for really taking care of patients, a low FeNA doesn't rule anything out, and you're going to have to deal with the full realm. And the other thing I'd like to also emphasize is the specificity of the urinalysis also falls off, is that when you have an elevated bilirubin, which these patients typically have, typical Highland casts get real stained and will often be misread as dirty granular casts, and you may misinterpret that UA as an indicative of acute tubular necrosis, when all it is somebody who could be either pre-renal or hepatorenal syndrome, which will both have these stained Highland casts. So you just need to be real careful and not to prematurely jump to your diagnosis.
And Highland casts generally benign finding, just kind of protein. Yeah. They're usually clear, but you're saying in the presence of bilirubin, they're just kind of stained that color.
That's exactly right. So we see these Highland casts anytime you get concentrated and acidic urine, which is going to happen in, first morning urines have a lot of them, pre-renal patients have a lot of them, and cirrhotic patients going to have a lot of them.
JC, is there anything you would add to the differential diagnosis that Bill was highlighting there?
Before I would do that, I would try to just emphasize a couple of things. So assessment of these patients is always challenging. And I think that at the end of the day, you just need to do everything that everybody does, but just do it as best as possible. And that starts with the history and physical. You cannot underestimate the power of that. If you have somebody coming in with 15 bowel movements on lactulose, you're gonna have to do you're gonna have a hard time convince me that patient does not have just prerenal azotemia. Did anybody double the spironolactone to 200 milligrams a day recently, a week ago prior to? Those elements in the history are very, very helpful. So that's the exercise that I try to do, get a lot from the history. And then once you examine the patient, it's also important, if you look at all the reviews and recommendations about hepatorenal, talk about volume expansion first, given albumin. And if you have somebody that comes in with cirrhosis and has got bilateral hydrothorax and maybe some even pulmonary edema, very edematous, you can't just volume expand those patients. It could be detrimental for the patient. So those things that you have to do always in the beginning.
You were describing kind of two different patients, one patient who's clearly hypovolemic, and then another patient who's got pleural effusions, edema, ascites, are clearly volume overloaded. How can we approach those two patients differently? What would you do with those patients? Maybe we'll take the volume overloaded patient first.
Well, I guess the importance of that is that as we're going to probably discuss throughout tonight later on, is that a lot of times when you assess these patients with acute kidney injury in the context of cirrhosis, if your initial workup with the urinalysis is unrevealing, urine sodium is less than 20, everything else is equal, you're kind of forced in a situation, okay, this patient could be hepatorenal, but could also just be volume depleted. And it's important to assess the patient before you just pull the trigger with albumin. If a patient has signs of volume overload, further volume expansion could be detrimental to the patient. And you don't have to follow the book necessarily. You have to deviate and look at the patient and say, all right, I'm not going to volume expand this patient. This patient is already probably into a hepatorenal physiology. Conversely, if you have a cirrhotic that doesn't have any peripheral edema, how often do you see that you don't find any kind of bottle-like edema around the ankles? Then I start to wonder, if this patient doesn't have any peripheral edema and his ascites is kind of soft, maybe that's an indication of volume depletion for that particular patient. And I'll be much more confident with a trial of intravenous albumin for the first 24 hours. So those are the things that I use to try to decide my first steps when you assess these patients.
Hey, JCV, you use that term hepatorenal physiology. Can you just kind of walk us through what you mean when you say that?
Yeah, it's kind of something that I've adopted from tradition, really. I see here in my former mentors, Jim Tomlin, Charlie O'Neill at Emory, when I was a fellow, they would use it. And even when I was a resident in Chicago, my mentor, John Ball, would use that. And it kind of made sense to me that, we try to have this dichotomized approach that whether you have hepatorenal syndrome as the only cause of AKI or you don't. And that clearly is really not the case. Even it's the same situation when we talk about prerenal azotemia and ATN. Those are ends of a spectrum. So when I say hepatorenal physiology is that you have a patient with advanced cirrhosis. They have circulatory dysfunction with peripheral vasodilation and splenic vasodilation and renal vasoconstrictors, increased levels of increased activation of sympathetic nervous system and the renin-angiotensin system. All that is in place, and that's definitely going to affect kidney function to some extent. And so you could be volume depleted and have the same pathophysiology going on at the same time. You could already have intrinsic tubular injury, but you can still have all the same hormonal systems trigger and active. So I think that's why I try to use that terminology to recognize that you can have coexistence of more than one pathophysiological process in the same patient.
And JC, this is why it's difficult for us as internists. Let's say you're in the hospital, you're seeing this patient, they come in and let's say we think they're dry based on the history, like the example you gave, they've been having 15 bowel movements a day from lactulose. Should we be giving them, and their creatinine's 2.6 like this patient, would you choose colloid? Would you give albumin as the fluid? And then there's more than one type of albumin. So which one should we give? If you could be specific so our audience can kind of try to actually use this information in practice.
Sure. I have to say that I don't have necessarily any position that is very strong about the percentage of albumin. Typically we do the 25% or 12.5% albumin that is available in the hospital. I am not aware of anybody publishing a study comparing 5% versus that. I'm not even aware of anybody comparing colloids versus crystalloids in the setting of cirrhosis. A lot of what we do in the management of these patients come from this international club of ascites that have shared their expertise through many years, and they decided to provide guidelines. Many of those guidelines are based on their expertise, and of course there is some foundation to support the use of albumin in cirrhosis, and that's what I do. I do think it's probably more effective, but I don't know if we have really strong science to show that it's better than crystalloids.
Yeah, JCV, I kind of have the feeling that the volume and distribution of saline in the presence of cirrhosis is essentially infinite. That saline that you give just ends up in their ascites very quickly and is not an effective solution. And so in those patients, I'm also reaching for colloids.
Yeah, no, absolutely. I think that's what we do. We've been doing that, and that's kind of the general recommendation. I guess my point is, if you have a cirrhotic that presents with volume depletion from lactulose or from diarrhea or from overdiuresis, occasionally I do both. I give him albumin and may give him some saline along with that. I mean, it's not the norm, but when the patients are clearly volume depleted, I may use both, but not commonly.
And I think your point's a good one. There's this big spectrum here of this hepatorenal versus ATN versus pre-renal, and we're always trying to figure out which one it is. But you know what? Pre-renal is going to get better if you get more blood to the kidney. Hepatorenal is going to get better if you get more blood to the kidney. And ATN eventually is going to get better if you give enough time and give more blood to the kidney. So we're always trying to establish euvolemia in these patients. And the only way to establish euvolemia in any patient, because there's not a good test for volume in anyone, is to go in and look at them. And just like Juan Carlos is saying, is if they are massively, for cirrhotic, if they've got a kind of a softer belly, by the history, they've had all these bowel movements, maybe you need to give them some intravenous volume resuscitation, and usually we choose colloid in this situation. But if they've got JVP up the wazoo and they've got RALs, we know we're going to be taking more of a nephrocentric viewpoint to diuresing the heck out of them to get rid of all their ascites and everything. So a lot of it comes down to the bedside, which is sometimes hard to figure out on a board's question.
Bill, what diuretics might you choose? Because it's always been a bit confusing to me. I know when you read spironolactone is supposed to be the first one you give. How do you start diuretics on this patient? Let's say they come into the ER and they're the patient that we think is more on the volume overloaded side. What might a starting regimen look like?
The different diuretics are confusing to some people, but they kind of all come down to how much water and how much volume you're trying to get into your urine. And in a patient with cirrhosis, they have water overload and volume overload. And so it's really nice to pick a diuretic that gets rid of both. So I usually start with a loop diuretic, but knowing the pathophysiology is such high activation of the renin-angiotensin-aldosterone system, I'm very quick to add aldosterone antagonists. So I'll often do both together. Well, I'll give a loop diuretic and aldactone, watching, of course, for the potassium. We typically, in the cardiorenal patients, are even using metolazone or some of the loop diuretics, but some of the thiazide diuretics, but those can sometimes get you into trouble with further hyponatremia. So I typically stick to loops and aldactone.
Joel, any magic to the starting doses there? Is it like, do you keep to this ratio, the 100 of spironolactone to 40 of furosemide?
I'm a little hesitant to load up spironolactone in patients that have failing kidneys.
Right.
I get, the thing that's going to push you to force you to decide whether you're going to dialyze or not is going to be that hyperkalemia. And I'm reluctant, unless I see good urine output and a kidney that I'm convinced is going to be doing okay, before I start hitting them with high doses of spironolactone. Yeah. Much more comfortable with furosemide.
So for this patient here, I want Joel, I'll ask you to nickel down on what dose of Lasix might you hit him with? Are you going to use your 20 times creatinine formula?
Never fails.
Okay. Okay. So 20 times 2.6.
Actually, let's back up a little bit. Because the patients with cirrhosis oftentimes have a lower creatinine than you would expect. They tend to have their decreased muscle mass, decreased creatinine production from their liver disease. Their creatinine probably overestimates their GFR, and their kidney function is probably worse than what you would think just by looking at their creatinine. So I may push a little bit higher on that Lasix dose than the 20 times creatinine.
Okay. So instead of roughly this person would have been around 60, so you might give them 80 or more to start with.
That's right. That's exactly right.
All right. Okay. I think I'm getting this. So for this case here, we sort of talked about the basic workup. Actually before I do the recap, I wanted to ask, JC, is there any evidence to this ratio? I sort of asked Joel about it. When I looked back, it looked like there were maybe some papers from like the 80s or something where they initially were trying spironolactone versus spironolactone plus Lasix and seeing who got hypokalemic, who got kidney injury. Do you know of any? Do you believe the evidence that we have to have them in these ratios to treat patients?
Well, I remember reading that literature in the context of management of refractory ascites, but not in the context of acute kidney injury. And it is all literature. I have to say, I admit I don't recall the specifics, but I remember learning that as a student that has some foundation to use it. But I don't think it's something that is necessarily useful in AKI. Particularly, as Joel has mentioned, spironolactone is not something that we use a lot in AKI.
That's true. It was when we talked about it on previous shows. It was in the case of refractory ascites. So I guess we don't necessarily have to apply it to these patients that we're talking about, or the case here. The next question, kind of back to the differential diagnosis. These patients could be obstructed as well, and usually I've seen that they say you have to get the renal ultrasound. Now this is another thing we've kind of fought about on previous episodes, where we think the renal ultrasound, unless someone has risk factors for obstruction, it's kind of a low yield. JC, do you think is that something that you get on all? Would you get one on this guy? He's not really giving us a history of obstruction. No, he has no issues with BPH that we know of. No history of kidney stones.
Yeah, we always get a renal ultrasound, but you're right. If you want to be really accurate with making statements, you would say renal ultrasound is a mandatory test in the assessment of chronic kidney disease, but is not a mandatory test in the assessment of AKI. But 99.9% of the times it gets ordered. And I am guilty myself. I would say just get an ultrasound, just complete the workup. But if you ask me the question, whether it's always needed, I don't think so. I don't think it's always needed. And not only the history, the suspicion, is also the urine findings. If you have a urinalysis that shows no protein, no blood, then it's less likely that you're going to be dealing with some sort of parenchymal renal disease. But if you have hematuria proteinuria, at that point, you must obtain a renal ultrasound, because you can have some distorted anatomy that is going to point you in a different direction when you look at a differential.
Okay.
My feeling on that ultrasound is it's a test that has no risk to the patient, and it is one of the few causes of AKI where you can fix it. Yeah. Right. This is if you find that obstruction, like, to me, it's unacceptable to ever miss that.
Yeah.
To have the treatment of obstruction is not dialysis, right? We have effective ways of taking care of that. And I completely concur that its cost benefit ratio may not work out, and it's positive very few times, but I think it's unacceptable to miss that diagnosis. That's why I always order it.
The workaround we had suggested, it might be a little complicated in someone with cirrhosis and ascites, but bladder scan, or you can, if you can palpate the bladder, put a Foley in, drain the urine,
Bladder scan and cirrhosis with ascites is a really tough one.
Yeah, right.
But I get it. Obviously, if you're going to the masses, you shouldn't order renal ultrasound on anybody. No. But just like everybody said, it's relatively inexpensive, low risk, and reversible cause of renal failure.
Yeah.
Hard to say you don't want to order that test because you can miss something irreversible.
And are you recommending a Foley? Bill, I'll ask you first. Do you generally put a Foley? Let's say this patient was oliguric, creatinine 2.6 coming in the door. We're going to be, we were talking about the case where we were thinking we might do diuretics if we think they're overloaded. Are you putting a Foley in those patients, or do you think that's necessary?
Yeah, I'm not sure that I'm allowed to do a Foley catheter at Rush anymore, because every time I've tried to do one, everybody yells at me about CAUTIs, which are these, catheter-associated UTIs. And of course, as nephrologists, we don't really need a Foley just to measure urine output and make ourselves satisfied. We can use other tests to sort of differentiate those. But if you have a man who comes in with renal failure and it's undetermined what the etiology is, a Foley can be diagnostic and therapeutic. So sometimes I will put that in. Although this guy may have platelets that are low, he may have an INR that's high. There may be other complications with that, and he's got some pretty other obvious reasons for acute kidney injury. So I don't think that I would go in there and start screaming about how this person didn't get a Foley. When I come in the morning after the night on morning report or something, I'd be okay with not having a Foley in this patient since we have so many other etiologies of his renal failure.
I'm gonna move us along with our case a little bit, and we've talked about some of these things already. So let's say I've already given you the patient's creatinine's 2.6. He says he's peeing less. Urinalysis, there's no protein, there's no hematuria. We do get the renal ultrasound. It just shows mild chronic parenchymal disease. His urine sodium is less than 10. There were no muddy brown casts on the urine microscopy. urine eosinophils were ordered just to piss Bill off, and they're negative.
Shocking.
Yeah,
Shocking that they're not helpful.
And we stopped. He was on he was on trim sulfa, which we stopped along with the diuretics. We're back to saying, let's say that this was one of the patients where we felt coming in the door, we weren't exactly sure of the volume status. We decided it wasn't really pointing strongly in either direction, so we decided to hold the diuretics. So at this point, it seems like the initial kind of where we are, the initial workup's negative. So now we have to try to figure out how to perfuse the kidneys, right? How to get blood flow to the kidneys, Bill. And maybe I'll try to summarize a little bit, and then you guys can correct me if I'm missing anything, just to make sure. We said we're definitely going to do a history and physical exam. See, is this person gaining weight? Do their lungs sound like they're filled with fluid? Their legs and belly feel like they're full with fluid? Or is this the person that says they've been nauseous, vomiting, having diarrhea, haven't been able to eat or drink anything? Those are the two extremes. Unfortunately, a lot of the times we have people in the middle, and that's kind of where it becomes tricky. We got the basic workup, which was just sort of some urine sodium, maybe calculate a FeNA, renal ultrasound, or place a Foley if you're allowed to at your institution, and then from there, JC, why don't I throw it to you? What might be a next step for the patient where you're not quite sure about the volume status?
Yeah, so that's a very common scenario, right? And unfortunately, in this field of nephrology, a lot of times our best diagnostic tests are our therapeutic trials, right? We are in a situation where we think this could be the diagnosis, but we're never certain. Rarely, I wouldn't say never, but we're rarely.
Oh, JC, you cut out for a second. You said we're rarely certain, I think you were saying.
I may be able to help finish what he was saying. Yeah. I don't want to put words in his mouth, but I think that any volume issue is, like I said earlier, difficult. If it's cardiorenal or hepatorenal, we have tests for water, right? I mean, I know when someone's water depleted, they're hypernatremic. I know when somebody's water overloaded, they're hyponatremic. Those are easy to define and determine how much water someone needs removed, how much water someone needs to be given. But volume is an assessment. It's a judgmental assessment. And what you need to do is obviously look at the patient, like we've said. And then the one thing that you don't do when you're worried about a volume disorder is you don't treat with both diuretics and volume resuscitation at the same time. There are times when I will give Lasix and normal saline at the same time. I may be trying to get rid of potassium. I may be trying to get rid of water and fix somebody's hyponatremia. I may be trying to get rid of calcium. There's all sorts of reasons to do so. When you're not sure of someone's volume, though, giving them intravenous volume and Lasix, same. So what you end up doing clinically is you kind of pick one. You go into the bedside, you see if the patient's what you think is more volume depleted versus volume overloaded, and you pick that. So you diurese the heck out of them the next day, and they're more azotemic, and you were wrong. Or you give them 7 liters of normal saline the next day, and they're intubated, and you were wrong. But and I'm sort of joking, but at the same time, then because you haven't done both at once. If you do both at once the next day, you're screwed. You have no idea what happened. So you pick one based on the least clinical harm and based on your best judgment, because that's what volume assessment is. And then you go with that, and you kind of go all in on that. And then you decide if you've made them better or not. And honestly, in most cirrhotics, especially if they're hepatorenal, and they're always a relative hepatorenal because of the lack of the blood to the kidney, it's really hard to make them better until their liver gets better.
Joel, anything to add there? You were nodding a lot, so it seems like you kind of a lot of that resonates.
Yeah, I think we're cut from the same cloth. We're both clinicians first. And the only other thing that bothers me is when someone says, "Okay, I think they're volume depleted," but then they give 75 cc's an hour of fluid, and so the next day you're like, "Well, we did give them a fluid challenge, but I'm not sure if it was enough." Like, don't. Make sure you give enough so that if it didn't work, you're going to say we were wrong, not that we didn't quite get there. Like you're giving yourself 24 hours to do it. give enough that you're going to be on one side of the fence or the other by the next day, and never go and not saying, maybe we need to do this for another day.
Yeah. Yeah, and I completely agree with that, Joel. This is one of the things and that applies to any form of AKI. When you are deciding to do a fluid challenge, I always tell the residents on my team, hey, what time is it? It's 4:20 p.m. in the afternoon. We get this consult. By the time you give your recommendations to give fluids and the residents get the message and then pass on to put the orders in the computer, the nurses get it, the pharmacy ships the drug to the floor. It's midnight before the fluid bag is at the bedside.
And the next blood draws at 4 a.m.
Yeah. So it's always that. So it's always try to make sure that you plan it correctly. So the next morning you have an answer that the intervention worked or not.
I was reading that the albumin is one gram per kilogram. 1 gram per kilogram per day for at least 48 hours is sort of the traditional albumin challenge. Is that something that you're routinely doing? Or you mentioned maybe giving saline and albumin. I know saline's much quicker to get your hands on, so that's probably what I would start with, especially when I'm first seeing the person.
No, I think that the volume expansion should be done with albumin in this patient, 25 grams IVQ6. The only instances that I recommended adding saline is when the patient was in an obvious state of volume depletion and I have a clear history and exam and I am convinced I'm going to give him more than just the albumin, but that's not the norm. The norm is just to do the traditional 25 grams IVQ6 for the first 24 hours and reassess.
Got it. Okay. JC, I wanted to ask real quick with the albumin that we're giving. Can you kind of talk about how that relates to the pathophysiology? You mentioned before splanchnic vasodilation. Can you kind of walk us through that again and how these different therapies that we're gonna talk about are gonna hit each part of that?
Yeah, sure. So this cirrhotic state, it's a state of hyperdynamic circulation. The stiff liver triggers a number of vasodilators, primarily nitric oxide, that causes splanchnic vasodilation. So that leads to a very poor effective circulatory volume that is read by the sympathetic nervous system and the renin-angiotensin system that subsequently lead to release of vasoconstrictors, norepinephrine, angiotensin 2, etc. There's also a different pathway that leads to this renal vasoconstriction, which is known as a hepatorenal reflex. Not a very popular hypothesis of the pathogenesis, but it's very intriguing. It relates to increases in portal pressure itself, sending a sympathetic signal to the brain back to the kidney to trigger vasoconstriction. So it's a mechanism that doesn't really relate to the effective circulatory volume. And so those are sort of two different lines of thought of how the kidneys end up with sustained vasoconstriction. And obviously they have hypolbuminemia, they have this poor effective circulatory volume. So with albumin, you're kind of trying to replenish that, maximize the effective circulatory volume. But it's also interesting data showing that albumin actually it kind of models the endothelial dysfunction that occurs in hepatorenal syndrome, and in a way tries to mitigate this peripheral vasodilation that occurs in cirrhosis. So although we think about albumin as a volume expander, it may have an effect that directly attacks the pathogenesis.
Yeah, there's some thoughts that albumin, and I don't know if this has been discredited, but I've heard people banter around that albumin may bind some circulatory factors that are directly causing the vasoconstriction. Is that something that's still considered a viable hypothesis?
Yeah, that's the same literature that I've come across.
I've never heard that before. That's really interesting.
So and then you get to that point. The next step is a vasoconstrictor. So why would you use a vasoconstrictor to treat hepatorenal syndrome, where as I said, this splanchnic vasodilation appears to be sort of a trigger for the maladaptive renal vasoconstriction. So by using a vasoconstrictor, you would sort of reset the signal that goes into the kidney and kind of counteract this vasoconstriction. And when you try to look into the history, at least I've tried numerous times to see why is that we kind of stuck with this vasopressin analogs. It appears that vasopressin V1 receptors are expressed in the splenic circulation, but it's not the only system that controls the blood flow in the mesenteric vessels and the splenic circulation, but there's one of them. So essentially, you just want to restore that. That was kind of the foundation why mydroden octreotide and ornipressin, terlipressin, and vasopressin were tested back in the sort of late 90s when the studies started.
So I'll throw this question, Bill. We can start with you, and we'll see where we get with this. Everyone else can chime in too. Let's say with our patient here, so he was oliguric, creatinine 2.6. We gave him the albumin challenge. Let's say we even did almost 48 hours. He got 100. He got the 25 Q6 of albumin, and now creatinine's actually worsened. His creatinine's 3. How soon do you pull the trigger on these vasoconstrictors that we're talking about here? And and let's just start there.
Classic teaching again from a lot of hepatologies. Once you define it as hepatorenal, that's when you start into this hepatorenal cocktail, right? Which sounds sort of exciting and sexy and all that. And that's what hepatologists mostly are, right? We can't disagree with that.
You've told it. You set that up from the beginning tonight.
Yeah. So in somebody who hasn't responded to volume, and a lot of in reality, in real life, I don't necessarily even wait to somebody not responding to volume, because most of my patients come in already so overloaded. They don't have a history of having a recent peritonitis or a new onset peritonitis, which might make you a little volume depletion or volume depleted and kick you over the edge. But a lot of my patients, if I've gotten to that point where we've given 2 days of albumin, there's no response, I've already started the hepatorenal cocktail 24 hours before. And in this country, we use the hepatorenal cocktail of midodrine octreotide and albumin. And if it was in Europe, we would be using terlipressin. And there's a lot of different trials, which I think JCV can hopefully go through some of these to differentiate which one is really the best and what may be the best for the future.
Yeah, so I agree. Midodrine octreotide is the most popular cocktail used in the United States. Unfortunately, in our institution, every cirrhotic that arrives to the emergency room with the creatinine that is a little bit above normal gets midodrine octreotide immediately as part of the initial orders, which kind of muddies the picture when you try to then assess whether the patient is HRS or not. It's hard to do that when the patient has been already receiving vasoconstrictors on admission. And then it comes down to what is the most effective. And midodrine octreotide has a role, is a very inexpensive combination that can be given oral and subcutaneously in a regular floor. So it's convenient, and there is some data showing some degree of efficacy. And in my personal experience, hasn't been very successful, but a small percentage of patients may respond to that. When you look at all the clinical trials that have been tested, that have been conducted to test different drugs for hepatorenal syndrome, ultimately comes down to the mean arterial pressure. What is the achieved mean arterial pressure during the trial? Whether you use midodrine octreotide, terlipressin, and the one that I particularly use a lot, which is norepinephrine. It always comes down to when the signal for renal recovery is strongly associated with improvement in mean arterial pressure. And it could be a debate about, how high you want to push the map. That's sort of a different topic. But the bottom line is that if you look at a very small trial in 1999, if I remember correctly, they designed a study to push the mean arterial pressure by 50 milliliters of mercury with midodrine and octreotide. And it's something that gets lost because a lot of times patients get admitted, the hospital medicine team starts the midodrine octreotide combination. but there's really little attention to the mean arterial pressure. And it's sort of an inertia there. 72 hours later, they're thinking, well, let's consult a nephrology. Nothing has happened. Well, of course, the dose was never touched. It was left at a starting dose, and that's something that needs to be emphasized. And that's why I often go straight to norepinephrine, because it's just more effective raising the MAP, and I can get an answer a little bit faster.
Hey, JCV, if you have a patient who looks like a hepatorenal syndrome, but they have a systolic blood pressure of 130 or 140, do you kind of eliminate that from your differential?
Great question. If the mean arterial pressure, and I don't know if I necessarily, I guess systolic above 140 I start to get less and less excited that I'm in front of an HRS. Yes. you gotta go back to again, these old papers tell you the real story. When the hepatorenal syndrome was described in the 50s, early 60s, there were patients with blood pressures of 100/60, with sodium was 128. They were oliguric. And that's the type of phenotype that, and amazing, those three factors that I just mentioned, they are not part of the diagnostic criteria from the International Club of Ascites.
I know.
They put all these criteria that are so irrelevant, and the bottom line is that the phenotype of the patient is not in the definition. So yes, I pay a lot of attention to that. Having said that, it's interesting because you can have a patient with a blood pressure of 125/65. The mean arterial pressure may be 78, 80. That, you may think that that's inconsistent with a hepatorenal syndrome, but it's not necessarily inconsistent, because there is sort of there's a shift. There's an autoregulatory curve that has shifted. And in a patient, in a normal individual, a MAP of 75 is a great MAP, a great mean arterial pressure. But in a cirrhotic that presents with a MAP of 71 or 72, he may need a MAP of 90 or 85 to adequately perfuse the kidneys. And that's something that that I pay attention to.
The norepinephrine you were talking about, that those patients they need a central line, and they're generally in the ICU when you're doing that?
Yes, that is unfortunately a limitation. There are some hospitals in the country that have had just anecdotal conversations that have implemented protocols in step-down units, and they can use norepinephrine. It's something that I am trying to also implement in my hospital. But yes, most of the times, or almost universally, norepinephrine requires intensive care unit transfer, which obviously is a limitation, because you have to, as a consultant, communicate your recommendation to the primary service, which then is going to call the ICU, and the ICU is going to call you back, and you're going to be in this triangle negotiation to try to transfer a patient to the ICU who is otherwise normotensive in the eyes of the intensivist. So there's a little bit of a disconnect in the understanding. And sometimes you call and you say, hey, this is what I would like to do with these patients. And sometimes, yeah, that makes total sense. Let's do it. And then, I go on my computer late at night reviewing the what's going on with the patient, and I pull the maps, and the maps are like 65. And I call the ICU nurse, and the ICU, yeah, we're doing MAP of 65. That's what we do for Levofed. And so many things get lost in translation. It's not a common approach to give norepinephrine to a goal MAP of 85. So even when you want to do it, it doesn't get executed properly.
Joel, it sounds like you need one of your checklists.
Or improved communication.
Yeah, there you go. These were brilliant recommendations tonight. Well, the thing I wanted to point out, so our producers had done a bit of kind of looking into literature. This Wang et al. Did a systematic review last year where they looked at terlipressin head-to-head, terlipressin and albumin versus norepi and albumin versus the midodrine octreotide albumin cocktail, and it looks like norepinephrine is at least as good or better than terlipressin. But terlipressin, from my understanding, it's just more convenient to give it. So do you think that's going to be coming to the States at any point?
Matt, can I just step in? Because I know what I know what I wanted to say when you asked that. And I think what I want to, when you are thinking about moving these patients to the ICU, I think you need to think about what is the prognosis of the patient who has hepatorenal syndrome that you do not reverse. And those patients are going to die, right? If you have a classic type 1 HRS where their creatinine is going up, and if they're not going to get a liver transplant quickly, within a couple of weeks, they're probably going to be dead. And so, you might want to talk about how much it costs to move the ICU or what a hassle it is to do, but we are truly dealing with a mortal condition here. And you're talking about here's our last chance to save this guy. And so,
fantastic
push.
point. Yeah. So it's worth it. Essentially, you're saying it's worth it. If that's what the patient has and that's the right thing for the patient, you got to do it. And I don't think anyone's gonna. I mean, you could fight. It's worth fighting for that.
That's my point.
It is absolutely. It's a great point, Joel, and that's when once again comes to really assess your patient very well, because you have a cirrhotic patient with a bilirubin of 34, encephalopathic, really very, very ill, with very low, that is not going to get a liver transplant. That you think, even if I revert his kidney function, how much better this patient is going to be? What is his life expectancy? Is his quality of life going to be meaningful? But so that patient, I'd say, maybe this is a patient that we need to call palliative care. But all cirrhotics are not the same. You may have a highly functional cirrhotic. It just happens to get HRS1. That patient is worth the fight and give him a chance to go to the ICU.
And not just the ICU. 15 years ago when I was in fellowship, if it was an alcoholic cirrhotic, especially with the recent drinking, it was not an indication to do dialysis once all the other therapies had failed. Obviously, if you're really hepatorenal and you're not a liver transplant candidate ever, then you're not going to put this person's last days on dialysis, and you really do need to invoke palliative care. And either way, we need to invoke palliative care. But nowadays, at least, for the patients who are alcoholic, if you can keep them alive for 6 months and they can abstain during that time, then they might become a liver transplant candidate. So if you get to the point where that's where nephrologists are really getting, is not when to start hepatorenal cocktail as much as when to start dialysis in someone who's failed. And we are often struggling with this, but in a patient who is a recent use of alcohol and hepatology comes by and says they're not a candidate for transplant, you still have to give them that chance. If you can keep them alive for 6 months, they may be a candidate for transplant. Now, how often does that actually occur? Probably less than 10% of the time, but you still have to give them that chance.
Yeah, and I would concur with Bill there, is that I was taught that hepatorenal syndrome was a disease that you did not dialyze. Like that was the dogma when I was a fellow, and we have definitely changed that, and in selected patients we offer it.
I wanted to quickly just JCV, I'll throw it to you. Hepatorenal syndrome, the type 1 versus type 2, how important is that to really kind of differentiate?
Well, when you are dealing with patients with acute kidney injury in a hospital and cirrhosis, you're almost always dealing with hepatorenal syndrome type 1. So the type 1 is a rapidly progressive AKI. Creatinine deteriorates fairly quickly within the span of 2 weeks and has all the elements of AKI. Hepatorenal syndrome type 2 refers for more of a chronic subacute insidious entity that I can say that occasionally when I see patients in clinic that come refer because they have elevated serum creatinine, they happen to be cirrhotic, and there's nothing you can find to explain why the creatinine is sitting at 1.8 and 4 months ago was 1.3, and there's really nothing else going on. I mean, this patient may have HRS type 2. There's not really a patient that I would put him on a hepatorenal cocktail or anything like that. I kind of follow them alone. They tend to be fairly sort of benign in the course. So I don't really use that diagnosis in a hospital setting often. I think it's mostly HRS type 1 what we see and what the real challenging patients are.
I wanted to ask about paracentesis before we start to sort of wrap up here, because it often comes up where the patient's kidneys are failing. They maybe they have tense ascites or massive ascites, and you're just kind of wondering like what to do there. Like you certainly at some point are going to need to do a diagnostic para on that person while they're in the hospital. But then there's always this kind of dilemma we run into: how much fluid? Should we tap them until they're dry? Bill, I'll ask you first, and then we can kind of go around. What's your tact in those patients?
Yeah, I'd like to actually hear what everybody says when we go around, because I try and get somebody euvolemia. You want to take off enough and not too much. You want to make sure they get their albumin back so that they don't drop their pressure. And I can't tell you how many times I've come by the next day and they got 7 liters of a large volume paracentesis, and they've gone from a creatinine of 2.0 to 2.7, and you say, oh, well, that's why, and they shouldn't have done that. And so I think I'm always a nephrologist, and we always think about the kidneys always trying to gradually remove urine from the person on a stable 24-hour basis, and that's why we like these CVVHs versus acute HDs every once in a while. It's the same kind of thing. I think gradual fluid removal is best. I'd rather have a 2-liter paracentesis every other day than 7 liters once a week in somebody. So you kind of it's a gestalt, I guess is the word. It's a judgmental decision, but I'd like to hear what everybody else thinks too.
I like the large volume. I like to get that fluid off them, replace the albumin. I'm happy to actually start the albumin beforehand, even if you anticipate a large volume. Usually you can, but I like getting that fluid off. I do worry about this tense ascites collapsing the renal vein and the IVC putting back pressure on the kidney. And so I think removing that fluid is the right way to go.
I find this area difficult. I think it's controversial. You open a textbook in nephrology and you're going to read one of the most common precipitating factors for hepatorenal is large volume paracentesis. And then you have this whole modern literature speaking about abdominal compartment syndrome, killing patients in the ICU. So you're kind of in the middle of, okay, which one is true? Right? It's really confusing. And the literature is really doesn't help you, is incomplete. There aren't a lot of papers that clearly show that LVP precipitates HRS. But like Bill said, I've been in that same situation. I see patients getting worse after an LVP during my practice. But at the same time, if I have a patient with a tense ascites and you measure bladder pressure and the bladder pressure is 28 and the patient's belly is about to explode and is very uncomfortable, of course, I want to send a patient for a paracentesis. So I don't really have any a clear answer. Obviously, I'm just giving you both ends, and that's how I am currently in this topic. I kind of go by the patient. If there's evidence of abdominal compartment syndrome and with very high blood pressure, I'm going to be very proactive about draining it out. But many times I do it and the patient gets worse. So I'm not sure. It's very difficult. It's a very difficult area.
I'm hearing that I'm not alone in finding this to be a conundrum and it seems this is one of those things, like we talk to specialists on the show all the time, and when we ask things where we see the practice just vary so widely, it's often because it's sort of an evidence-free zone or where it's a highly artful practice where you just kind of have to take it case by case. It sounds like this goes along those lines.
Let me just add a comment. So when you read the clinical trials in the world of hepatorenal syndrome, you look at the methods, they always make a little comment about whether paracentesis was allowed or not during the trial. And in most of the trials, it is allowed. So that kind of goes against the premise that LVP should be detrimental to the course of HRS, okay? And what I try to do also, if I have a patient that I am actively treating for hepatorenal syndrome with, let's say, norepinephrine, a vasoconstrictor, and I am pushing the MAP, and the MAP is going up successfully, and the creatinine is reaching a plateau, starting to curve down nicely. Without norepinephrine running, I am very comfortable sending that patient for an LVP with albumin, depending on the volume. I'm actually very comfortable putting back on diuretics because you are really maintaining renal perfusion with that map. And, we stopped diuretics before we diagnosed HRS, but once you're diagnosed and you're treating it, there's no reason not to bring the diuretics back into the picture if you're trying to remove volume. I don't know if...
Wow, that is pretty cool. I have not seen that done. That's pretty awesome. Joel, have you done that?
No, I was thinking that was pretty crazy.
I like
because
it.
Think about it. Hepatorenal syndrome is not a volume depleted state, right? It's a disorder of hemodynamics that you're restoring with your intervention. Once you restore it, if a patient has massive edema or urine output is not picking up, you could add a diuretic. And I've done it many, many times, and it is rarely a problem, actually.
Fantastic. Let me check in with our producer, Dr. Justin Berk, and see if we have anything that we're missing here before we kind of get some take-home points.
I don't think so. I think if someone wants to explicitly say that what specific triggers can cause type 1 HRS, we mentioned LVP, but not things like infection or anything else that are common presenting things. But otherwise, I think we've hit most everything that's been asked. And other risk factors for HR. I don't think so. I think we're in a good place. I think this has been great.
Yeah. So I'll leave that out there. Bill, is there any major triggers or risk factors we missed?
I think anything can kind of tip them over. They're so chronically volume challenged. You blow them a little bit in one direction and they're going to tip over with a little peritonitis or one too large of a volume paracentesis or whatever. And there's a lot of different triggers, even a simple UTI or hepatic encephalopathy, then they're not taking the rest of their meds and then everything tips over. But so I think there's a lot of different triggers, and it's really key, like JCV said from the very beginning, to take the appropriate history and physical to nail it all down. I was wondering if we could just briefly mention the diagnostic criteria for hepatorenal by the Journal Club, and I think that a lot of the problem that nephrologists have with this criteria is that it's not really specific to hepatorenal. We're so used to seeing renal failure of all sorts of types, and then we narrow it down on the different types of renal failure. But I think in the Ascites Club, or I can't remember the exact name of the different clubs that they use to define these things, but I think a lot of them are just non-specific terms to diagnose renal failure, which is good. You want to make sure you do have renal failure, but there's a delta creatinine, there's a change in urine output, and there's all these things that are important to make sure that you're in the renal failure realm, but they're not really specific to hepatorenal. For example, you can have oliguria in hepatorenal and ATN and obstruction and all sorts of different renal failures. So the reason I think nephrologists kind of have a problem with some of the diagnostic criteria is that it's not, we want a diagnostic criteria that's more specific to narrowing down if it's hepatorenal versus other causes of renal failure. And this kind of just throws you in its renal failure realm. And so I think that's what this whole podcast is about, is to really, how can we narrow down someone who has hepatorenal versus pre-renal versus ATN versus underlying GN or bile-acid nephropathy or all the different things that we've discussed.
Beautiful. Joel, any take-home points that you wanted to give? Sorry about that.
Yeah. These are less take-home points, but we're talking about hepatorenal syndrome because that's a region in NephMadness, and there are two matchups in this region. The first one is going to be terlipressin versus norepinephrine, and what that really represents is: do you think that terlipressin has a magic ability to correct hepatorenal syndrome, or do you think it's all about the mean arterial pressure, in which case you go with the norepinephrine, the one that's easily available in the United States at least. And so that's the first matchup. And the second matchup is actually something that we have not addressed here. I just want to briefly go into that. There was a pathology series that came out a few years ago. It was mostly autopsies, and they looked at people that had cirrhosis, and they found a very high rate of bile acid casts throughout the throughout the tubules. And they hypothesized that these casts were actually causing the kidney failure. And they were found in patients with both hepatorenal syndrome and without hepatorenal syndrome, but kidney failure at the time of death. And they were very frequent, and it was a pretty compelling story. And there's been additional data that's come out afterwards. And I think you have a nephrology field that's divided with half of people thinking that these are incidental findings, that you have these very high levels of bilirubin and they will form casts, but these are not pathogenic. And then you have another group of people that find these bile casts to be pathogenic. And if you go to I don't think we're going to talk about that further here. But if you go to the NephMadness site, there's a real nice description of what the data is. And we've got an essay from actually one of the authors of that original PATH study. Anthony Chang was one of the authors, and he wrote an editorial about that, and he'll give his perspective. But that's the other region. And so when you go to NephMadness, you'll get to make your call. Bill, how do you go on terlipressin versus norepi?
I've got to put down my nickel.
Yeah, I got to lay it down.
I'm going norepinephrine for the win.
Okay, and bile acids pathogenic or incidental?
Even though Tony Chang is from Chicago, I am going to go that they are not pathogenic. He may kill me, but I'm going to say they're not.
Okay, and then terlipressin versus non-pathogenic.
No, I think I picked norepi.
Norepi to finish the
Sorry,
region.
yeah. So
JCV.
Norepi wins it all.
JCV, what do you got? Norepi versus Terli. I know what you're going to say though.
I go with miniature pressure, i.e. norepinephrine, to win that bracket.
Okay, all the way through. Very, very good. And just to complete the bracket, what do you have? Pathogenic or incidental?
I think I'm going to go with pathogenic. I think it's hot.
Nice.
And, I'm spinning the urine in all these patients every day, and I cannot tell you how many times I see beautiful renal tubular epithelial cell casts when the bilirubins are like 45. And it makes me wonder, those are not innocent bystanders. With epithelial cell casts in the urine, to me, that's a little bit of damage. So I think it's definitely exaggerated and overinflated. And Tony Chang if he's listening, he's not going to be happy. I think there's a lot of hype about that. I don't think it's that common, but I think there is something behind it.
Okay, I'm going to go with terlipressin over norepinephrine in the first bracket.
Woo!
And yeah. And I'm going to go with incidental finding rather than pathogenic for bile acid, and then I'll take terlipressin for the region.
Wow. Interesting. Yeah.
3 different answers all around.
Nice.
I'm gonna take norepi straight through because I just can't wait to put somebody on norepi and then try to restart the diuretics. That's one of my new goals in life.
So make sure the dialysis machine is close by.
Justin, we're not going to let you escape.
Terlipressin's a medicine I don't have available, so I don't know a lot about. The bile acids thing sounds weird too. So if I'm going to treat the bile acids, I'm definitely going to go with terlipressin for that. So terlipressin treating bile acids and normal saline for the win.
He's not licensed yet. It might be. Are you licensed yet? Okay. Thank you, everybody, for your time. This was a lot of fun. I know this is going to be really useful for everyone else, as it was very useful for me. So thank you.
Excellent.
This was really unbelievable. Thanks to Joel for having me involved, and thanks to you guys. I mean, it's really amazing what you guys are doing. So very cool.
Well, this one I literally could not have done without Justin and Joel. I got to thank you for dropping this whole NephMadness thing in our lap this year. This is I think this is going to be huge for both of us. This has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole. You can get show notes at thecurbsiders.com/podcast and sign up for our mailing list at thecurbsiders.com/knowledge food to get our weekly show notes in your inbox. And we're committed to providing you with high-value, practice-changing knowledge. And to do that, we need your feedback. So please subscribe, rate, and review the show on iTunes, or contact us at thecurbsiders@gmail.com. A special thanks to our wonderful writers and producers for this episode, Dr. Justin Lee Berk and Nora Taranto, who is graduating medical school in the coming months here, and to our social media team, Hannah R. Abrams on Twitter, Beth Garbatelli on Instagram, and Chris the Chew Man Chew on Facebook. Also, thank you to our friends at NephMadness and AJKD. Until next time, I've been Dr. Matthew Frank Watto, working tonight co-hostless, which is a term that I just coined. Good night, Stuart. Good night, Paul.
This is great, guys. Thank you very much for the invitation. This is really what you guys are doing is unbelievable. I'm a big fan of Curbsiders.
Thank you.
And try to listen to every time Kidney Boy is on, of course. I love when you guys, somebody told him when he did, I think it was the Acid Base podcast, that you guys said that his voice, if the kidneys were to talk, they will have the voice of Joel. And that was so funny.
That was. And then Joel's response was, if the kidneys could talk, it would be terrifying.
Yeah, I remember that. That was so good. Yeah.